Hi, everyone. Thank you for coming to our second episode of the podcast, Say Less Patient-Centered Communication. I'm Chris Haymaker, and I'm joined by my co-host, Kari Beth Watts. We're both in family medicine and medical education. Today, we are going to talk about trauma-informed communication. We have a special guest on the show, Stephanie Ellwood, a fantastic colleague and friend who is a family medicine physician. Hi, Stephanie.
Hi.
Thanks for
Thank you
being
for
here.
Thanks for having me. I'm excited to be here.
And I guess I wonder, I know that, Carrie Beth, I know that you spent some time cooking up questions that have not been revealed yet. I don't know if you'd like to lead the way.
Sure. I wonder if we want to first just maybe have Dr. Elwood, who we will intermittently call Stephanie as a colleague. Just do you want to maybe give your real brief elevator kind of pitch about who you are and what you do with Dr. Haymaker and I here at WMed?
Yeah, I would love to. So yep, I am Stephanie Ellwood. I am one of the faculty members at the Family Medicine department here at WMed and also the Associate Program Director for our Family Medicine program in Kalamazoo. And I am the Director of Osteopathic Education. So that means I do kind of everything with osteopathic medicine here in Kalamazoo as well. And so I have a role in clinical medicine at WMed in the outpatient and inpatient setting, and have lots of roles within education for our family medicine residency.
Thank you. And I know something that has been maybe an interest area of yours or has led to some projects with Dr. Haymaker and over time too has been the topic of patient-centered communication, which is the theme of this podcast. And what we wanted to hone in on specifically today was trauma-informed care, trauma-informed interviewing. And I think my first question is, a lot of folks, when they hear trauma-informed, I think that they sometimes feel that the onus is on them to elicit a trauma history, or maybe they feel like they don't know how to practice trauma-informed communication without knowing what someone has been through, whether they elicit it or whether it's offered to them kind of proactively by their patients. And I wonder how you approach patient-centered, trauma-informed communication in situations where you may or may not know what someone has been through. Like, what are some pearls for just healthy patient communication that is trauma-informed, that respects a potential history of trauma without maybe even that being revealed or elicited?
Yeah, I think that is such a great question. I think the first thing I think about, and when we're talking about trauma-informed communication or care, is really putting the patient in charge, right? So, and understanding and being able to give a little bit more power to the person in front of you to be able to sit with that and have that. So that means, and examples I'll give is asking for permission to even ask particular questions would be trauma informed. It's allowing the patient to say no, allowing the person in front of you to say, that's not something I want to talk about. That's not something I want to bring up. I would also say I usually go into a room when I'm having a conversation with the assumption that that person has had some kind of trauma. And I think with that assumption, then the way I'm speaking or the way I'm asking questions or I'm asking for permission just allows it to be in an environment that hopefully, again, gives a little bit more power to the person in front of me, because there can be those power dynamics that make it really challenging when you're sitting down with someone to be able to have an open conversation.
I love
I,
that.
I love that. Yeah, I mean, I really love how that respects the sort of possibility that anyone could be coming in with a trauma history. And we know that everyone benefits from that sort of autonomy in patient care, and that that's especially important for people who may have difficult experiences like that in their background.
I wonder if we can pause and even talk about what we all might mean when we say trauma. Because I think, again, a lot of times an assumption from other physicians, and maybe myself included, before progressing in my career as a physician and as a medical educator, my brain, when I hear trauma, goes right to the big stuff we might think of as real big issues, oftentimes involving violence, right, or aggression. Things like sexual trauma or assault, things like intimate partner violence, or other instances of being a victim of violence. And I wonder if we here together can kind of expand a little bit of what we've come to understand is important to acknowledge or consider, that folks have been through things that might be kind of on that ACEs list, or instances of medical trauma or healthcare related trauma. So I wondered, to both of you, Dr. Haymaker and Dr. Ellwood, what are some examples of things that you're considering when you kind of make an assumption that a patient has gone through some adversity or trauma? What are we talking about?
Yeah, I think I would start with what you were mentioning. Kind of, we started broadly, right? Thinking about, I think everyone kind of points towards that more extreme in the beginning of thinking about trauma. But when walking in a room, this could be, someone who's been part of the healthcare system since they were a child. And just the being in a healthcare system could be very triggering or very difficult, because they've had so many experiences that may have not been positive within a healthcare system. And so, when walking into the room, that might be something we're coming into where they don't really want to be there. They don't really want to have to engage, or it's difficult to engage because they've got like fight or flight and all the things happening as soon as they walk into a room. And so some of that is reading like how the person in front of you has nonverbal cues, and are they, kind of withdrawn? Are they looking away? Those kind of things can help clue you into these other events that may have happened. So that is an example that I kind of think about, but I'd love to hear Dr. Haymaker, your thoughts on that.
Yeah, I mean, I think it's so sensitive to be looking out for the experience of the patient as they're engaging the healthcare system. And then sort of zooming out beyond that, right? We've mentioned ACEs, or adverse childhood events. And one of the reasons why that's important to notice is that we know that adverse childhood events, and there's a list of them that we may or may not get into in the remainder of the podcast, but we know that those affect people's health pretty significantly. So if you have the more adverse childhood events you have, the lower your life expectancy, for example, the more likely you are to experience chronic disease in your lifetime. I think another thing that's on my mind as we're talking about it is that it's really pretty common for people to start with life-threatening. And like as a psychologist in my training, like the diagnostic criteria for something like post-traumatic stress disorder is experiencing or witnessing a life-threatening event. And I think we all know from experience that that's on the extreme end of things, and that I think our responses to different situations can take on a variety of forms depending on the strength of those stressful experiences that we've had. Maybe they've been specific events, maybe they've been sort of chronic, unhelpful or unhealthy relationships that have contributed to how we approach our real-time sort of interactions. And then that means that, for example, it could be that someone has had one of those adverse childhood events that makes them especially distressed, right? So that maybe they had a parent who was depressed when they were growing up, and that sort of affected things. Or maybe they are in a group of people that has poor access to healthcare, and they have often been invalidated by the healthcare system. And that can separately contribute to those sort of responses in the room with a doctor that can create those reactions. And so being sensitive to that, approaching those reactions with some curiosity and permissiveness, and then doing what you can to uncover just enough information so that you can be sensitive to the needs of that patient as sort of the ask in front of you, just enough so that you can connect. And that probably depends a lot on what you're trying to accomplish and the you know and the what the patient is trying to accomplish and how you navigate those choices about how you're going to use your time together.
I wonder what are some more examples of what that looks like, that uncovering, because I do think we're in encounters a lot where there is like a kernel of something, right? Or an awareness of either prior adversity or some suggestion from the patient, verbally or otherwise, that they're uncomfortable with, or struggling with, or kind of chewing on an adverse experience, either related to healthcare or related to their health. And so some examples, I guess, broadly I think of as like preparing folks for an invasive procedure, particularly people assigned female at birth who are preparing for perhaps a pelvic exam, gynecologic or obstetric encounter, and how we might do just enough in those situations to try to uncover or empower those patients. And maybe I also think of, like, in the other umbrella of folks that have maybe healthcare related trauma, how we can do just enough to try to unpack what we need to know to ensure that they're comfortable moving forward. So I guess to either of you, maybe I'll start with Dr. Ellwood from a kind of that low hanging fruit of ways that we can tangibly, what questions to ask or what phrasing or scripting we might use to empower a vulnerable patient, where we're going to do a physical exam and we want to kind of uncover their comfort level, where they're at with it, prepare them for it. What does that look like?
I really love that question. And I guess I will also preface it with, we will all make mistakes. I have made mistakes. So there is no perfect scripting. There is no perfect thing to say in the right moment. One thing said could be actually really like not helpful to a patient in one instance and extremely helpful for the next. And I do just want to recognize that the like fumbling and the mistakes will happen. I sometimes give the example of a patient as I was walking by, on the obstetrical floor. Usually you'll place the kind of wires to the belly sensors around the patient's shoulders as they're walking to the bathroom. And as the nurse and I were doing that, the patient physically grabbed them, pulled them off, and was extremely distraught. And, that was something so routine that ended up being very traumatizing for the patient. And so I think I just want to recognize that those encounters, those things will happen, right? As you're on a learning journey for like what that means and how that looks for each individual person. So I guess some phrasing out for like more invasive physical exams is asking just previous experience. So have you had this exam before? And then tell me about it. How did that go? It leaves it open-ended so that the patient can actually fill in the details, versus asking like very specific questions like, do you have a trouble with pelvic exam? I think can feel not great to answer, versus tell me about the experience. And they may say, it was a terrible experience. Like I had this, and this happen. And then the next follow-up question is, well, what can we do to make that better? Is this something you want to continue or to proceed with? Because you have permission to say no. I think it's making sure that there is that permission to be able to advocate and say what is necessary in that particular encounter. And so those are probably like the important aspects, I would just say.
That leaning into sort of gently uncovering a patient's experience in that way that is not interrogative, right? What was that like for you? Could you describe your experience for me? Those are really nice ways of getting at that kind of principle that we want to be gentle and then offer opportunities. We know that on the one hand, people don't generally like to talk about their traumatic experiences. That's hard to do. It doesn't feel good when you're talking through it or re-experiencing it. So often humans avoid that. And so you won't know unless you offer opportunities. And sometimes you won't know if you do offer opportunities. And sometimes you'll need to offer opportunities where you get like just enough information so that you can proceed with care and not, I think, invoke the whole traumatic experience again, which can be re-traumatizing, right? So the idea of forcing a patient to tell a story instead of getting them to describe, allowing them, inviting them to describe an experience that may have been difficult for them, and that may not be directly connected to their trauma. So that idea of like, tell me about how it went last time, what was difficult about it, what feels okay to, what do you need in order to proceed with this. All of those things are really helpful when I'm wearing my psychologist hat and if I'm in the middle of a diagnostic interview and I know that I need to know about whether or not somebody felt really threatened, then I will often ask that yes, no, but then be really very permissive about any kind of follow-up. So I might ask, have there been times in your life when you really felt like your life was in danger or the life of people that you cared about were in danger or something along those lines? That's a yes, no. And then if somebody says yes, then I might say, like, if when you feel comfortable, it might be helpful for me to know what happened, and how that connects up with what you're experiencing right now. And we don't need to talk about that right now in this moment. And that's a sort of an element of when you're working with folks with trauma and they're talking about it, it's often quite uncomfortable, and it's often really important to attend to how much vulnerability they're offering in a particular moment and how much time they might need to armor up or recover from that vulnerability so that they can go back out in the wide world and appear okay.
I love that. And I think it is something that we try to train our learners is, you know, asking questions with respect for your capacity to respond to whatever the answer is, and so it's kind of like asking screening questions and then knowing, hey, if something comes back positive about their sexual history or their substance use history or whatever, that your responsibility is to be prepared to respond. And so when you're eliciting things like this, really being mindful of what do I hope to accomplish with this information? Both what do I need to know to do my job, and also how can I respect what I'm asking of the patient and disclosing that. And that comes with, I think, that permission piece that Dr. Ellwood keeps coming back to, and the idea too, like you're saying, Dr. Haymaker, that depending on the situation, there are times that you're getting kind of that just enough to be helpful, and that the questions we're asking are really, we're trying to signpost, like, I'm looking for this information so I can be as helpful as possible to you today, right? I'm going to get the information I need so that I can proceed with care and be helpful and supportive to you during this procedure, this exam, this interview, whatever. But also we do have permission, like if they give us information to say, and it could be the most helpful thing, like you're saying, Dr. Haymaker, to go, ooh, like that might be something that we might need to talk about more someday because for X, Y, or Z reason, as your primary care physician or as it relates to your health, your well-being, your whatever. And so maybe we'll come back to that sometime if that's okay with you and just leave it there to respect that space. And like you said, to know that person has to re-enter the world after seeing you. And so I really like that. And I think, again, this seems to be where that signposting is just so helpful. It's something I know we really reinforce with our medical students. And I wish we would have talked about more in my own medical training of just that importance of going, here's what I'm here to do or to talk about, and here's why it's important to me, you know, and then kind of opening up to the patient, like, you know, where can you meet me in this space? And with that example of the gynae exam or things like that, just being able to say really clearly, I want to proceed with care here. You know, what can you share with me that will help me be able to do that? I think is really empowering. One of the things I also, I guess, wanted to touch on as we talk about trauma related to frequent interactions with healthcare, whether it's through chronic disease, being the caregiver or parent of a child or family member with chronic disease, or an example I think of often now is patients like doing hospital follow-ups and patients that were recently hospitalized. I've read some literature lately kind of suggesting that we're underappreciating the prevalence of trauma related to hospital admissions. And I think particularly the literature is related to ICU admissions. But in general, kind of hospitalization, which is, depending on the situation, particularly with ICU, a time where one is fearful of perhaps losing their life or certainly confronting the limitations of their body and maybe confronting their mortality. And so I wonder from either of you what things we might do in these kind of often frequent encounters that many of us across specialties have with folks who were recently hospitalized, perhaps even went into like post-acute rehab or things that are so routine for us as people who see patients, but for a patient are like huge events, right? Life transitions or events. How can we maybe integrate some a trauma-informed approach to what we often see as a routine visit following up from a hospital stay for a sick patient?
Would it be okay if I just insert here? Like, I think part of what we're talking about related to signposting and related to, for example, hospital follow-ups where people have been in the hospital is that sort of continuum of loss of autonomy, that continuum of perceived threat. And one of the things that we know about people that have anxiety is that predictability is really helpful. We also know that offering them opportunities to talk about it is helpful so long as it's not an interrogation, so long as it's a sort of a reflection and a reintegration. And so, like, I suspect given that frame, one of the things that we could talk about a little bit is how the two of you and your interactions with patients post hospital or maybe even in the hospital are thinking about offering first that kind of predictability or signposting with patients.
I think it's a really good question. And I think sometimes, as Dr. Watts was mentioning, it feels so routine, right? So I think sometimes we can kind of get into a every day where, you know, seeing someone in the hospital and it's, you know, we're going in, we're going out, doing the things that we are needed for the care for that patient. And then when they come back out, we're like, oh yeah, we saw you in the hospital. We got to, maybe even care for you during that time and that transition. And I mean, the biggest thing I can think of when signposting or phrasing would be first initially is to sit down. So I think partly is just your own nonverbal cues and what that means to the person in front of you. I guess I'll give the example of a person we saw recently who had a very, very traumatic car accident. They were hospitalized, they needed surgery, they had multiple specialists involved. And they were now using a wheelchair when they weren't before. They were very ambulatory, like having like their life really disrupted from their standpoint prior to the hospitalization, and just sat down with the resident I was working with, and the patient just started tearing up. I was like, how are you? And in a way that really is eliciting, like, in you as a being, like, how are you? Not how was the surgery? How was the particular procedure? How have you transitioned home? But like, how are you doing? And then the person, the caregiver that's sitting right next to that patient in front of you, that person in front of you, and how are you doing? Like, this is hard, right? I think recognizing the difficulty and just opening up in an opportunity and signposting that I want to know how you are doing, not just medically, but in a whole person aspect, I think can definitely change the way we're proceeding forward, and hopefully, like, at least lessening the downstream effects that continue after that.
That is very similar to how I would have responded if I had been the one to talk first, was that importance of that sincere how are you, and thinking about, I think a lot of times these visits, they'll, like, for a post hospital, we'll come in and it's almost like the physician is like reciting back to the patient what their experience was, or like clarifying, like, you were admitted here to here, right? And you had surgery on this date, right? And you left with a drain, right? And it's, I think, the art there is really going, well, what if that's in the discharge summary? We know that. We know those things are true. And so where is there value in re-narrating the experience back to the patient versus that investment of just open-endedly going, wow. And that's what I find myself doing a lot, is like, whew, how are you? This was something, huh? Like, how are you doing? Or how have you been? Or what do you need? What's most important to you right now? What do you need from your doctors right now? And I think a lot of that actually, it feels like a big ask sometimes to physicians, I think, because you're like, it's scary to ask open-ended questions about a big experience. I think we're afraid we're going to get sucked in. And like so many other times that we do that, we find we're probably really investing in, it actually is more efficient than we think, because the patient's going to let us know what their needs are on the front end, or we're going to understand pretty quickly what is going to be a high yield use of our time today, right? If I came in going, oh, I want to know X, Y, or Z thing clinically, or I'm going to help them in X, Y, or Z ways, and the patient's like, oh, my mood is in the in the toilet, like, that's already okay. We're reprioritizing what we're doing today, and I use a lot of I believe you. And that's one of my favorite things to say to patients in any situation, when they're describing pain, or they're describing distress, or they're describing frustration over an experience, or is just repeating that, oh, I believe you. And I think that those are two really validating things to do. I will often too now, that this has been more in my awareness, with patients that have had prolonged hospitalizations, and if I'm the discharging physician, and we have a relationship where they're expressing some degree of anxiety about discharge or nervousness about the next steps, I believe you. First of all, I believe you. And that is, this is tricky, this is big, or this is big, or this must feel big, and just validating responses, but then also anticipating, like, it's okay if this continues to be hard. Let's, keep checking in about it when you see us in clinic, or it's okay to talk, like, to bring up with your PCP when you follow up. If you're still struggling, a lot of folks do when they've been in the hospital for a long time or had a big disruptive thing happen. So trying a little bit more in my role as a hospitalist to anticipate tricky transitions and give them permission to feel however they feel about re-entering their lives as a different person in a lot of cases.
I just wanted to take a moment maybe to distill some of this because it's so important for our theme of patient-centeredness, right? To lead with humanity. And that how are you, that is an offer of a connection, an authentic connection, and some space to react. And ultimately, I think that physicians wind up leading their patients in self-reflection about their health, and the way that you prioritize that can send an implicit message. So how are you really after something like that is so profoundly important. Sitting down is so profoundly important because even if you only have 15 minutes, it's so important to communicate to your patient that you have time. And time for this, and that this is a priority. So that being seated is super important. And I really appreciate that there's a sort of a contrast between confirming the inpatient course and eliciting the patient's concerns, which are like two different things, one of which can often be skillfully and efficiently accomplished through a review of the medical record, and another of which has to be in dialogue with the patient so that they can tell you their priorities, and so that they can help you navigate that arc of care in a way that's going to respect their reactions and the belief that they know themselves and their life and they are the expert.
I love that. That was just one of the pieces that I think when Dr. Watts mentioned, I believe you, I think that second piece of you are the expert for yourself and your body. And I think sometimes when I'm thinking about trauma-informed care and in medicine, there is this sometimes overarching or hierarchical thought that as a medical provider, I know more, when actually what I'm doing is synthesizing the information that you're providing, because you, as a person I'm seeing and working with, you're the expert, and I'm here to help understand it, right? And we're understanding it together. And so I think that's another very important aspect, and again gives more power back in that differential to the person in front of you, to recognize their own experience and their own just validity.
You just used the word we a bunch, and I wanted to emphasize that as well, because I think it's another skillful turn of phrase that we can use with patients to help show them that we're in it with them, right? We're going to figure this out together. We're going to talk more about this and try to figure out, and then for sure there are potential I's that you can stay to validate or underscore that, right? I want to help you to figure out what's going on here. I want to make sure that we support you in this process. And all of that does underscore our relationship with patients, with them.
I wonder if we can talk. I'm using I wonder a lot, but I wonder.
You're a
I feel
curious
like
person.
I am. I feel like I'm like Dr. Haymaker is rubbing off on me. I'm an armchair psychologist now. I wonder though if we can talk about some maybe kind of specific things to not do. We have normalized, I hope, and through Dr. Ellwood's anecdote earlier, and I'll emphasize, and I know Dr. Haymaker's emphasized, like the normalcy of stumbling. Like we are all constantly bumping into boundaries and making missteps, and especially because every person is a unique human. And so when we are trying to use our experience to inform that next encounter, those same techniques might not work, and that's okay. We learn and we grow and we put our foot in our mouth and we figure it out. And so acknowledging that we all stumble, and we want to normalize imperfection. And also there may be a few behaviors um, or messages that we really know we can consistently encourage people to avoid, when aiming to have a trauma-informed approach with their patients. And I'll give like the most, but maybe a benign, super low-hanging fruit example is I'm coming back to the gynae exam or an invasive exam, and we're telling someone to relax, right? It's almost never helpful and easily unhelpful, right? Or hurtful or triggering or. And so we'll say that's a super simple thing. Let's not, when someone's in a vulnerable position, ask them to relax. But what are some other opportunities where we're confronting a patient who is sometimes actively experiencing trauma or recovering from it, or just in general when we're trying to be trauma informed? Are there some themes or messages that we want to encourage people to avoid? Like, what are the pitfalls?
As
Dr.
we're
Ellwood.
as we're progressing through this, if there's one little thing that we could add to the activity, what should you do instead of saying relax?
And maybe, I know, I was going to say, Dr. Watts, if you want to give your example, and I would say what I normally say.
Oh, you go ahead.
So yeah, I laughed with a patient yesterday about using the phrase relax, because I said, as soon as someone tells me to relax, everything tightens, right? And so giving very specific cues for what you would like the patient to do. So I give the example, if we're doing a pelvic exam, what I'd like you to do is see if you can let your knees touch the outsides of the walls, or go towards the outside walls, and see if you can press your bottom. I use that phrase, and for some patients that might not be what they would like you to use, and so you can ask for permission about how they would like their anatomy talked about when you're doing a particular procedure. But I may say, can you try to see if you can place or push your bottom onto the table, like pushing down. Another phrase could be, specifically with pelvic exams, is thinking about using breath. So we know that the diaphragm and movement of the diaphragm can help release and relax tons of different muscles within our body. And so, is it okay if you're able to, can you take a nice deep breath into your belly and then let all of that out? Those are just, like 3 tips and tricks to try to have a more and I prompted, I say, I really want this exam to be as comfortable as possible. And so I'm going to give you some ideas or things to try to see if we can help make that more comfortable.
And really, the key there is speaking with specificity. So as opposed to the big ol' relax, which I think that we've all heard at one time or another when we were upset or stressed out and it didn't cue anything, coming back to really specific instructions with the end goal of being more comfortable helps us to navigate what potentially is a triggering situation with some more skillfulness and permissiveness and ease. And I think sometimes even people will prompt, please let me know if there's something that happens, right, during the course of this so that we can pause or. And so all of that is really specific. It's reinforcing patient autonomy. When I think about this sort of task, I think about like the contrast between what is a maybe triggering question or a mindset, which is what's wrong with you, and the more permissive and curious mindset, which is what happened to you. And so that like the example that I know from some of the trauma-informed care resources is just about a patient who might be late and then is landing in your exam room, maybe stressed out. And I think that there is a way that we can invest in our own perspectives so narrowly that we think, what is wrong with you, that you're late for this appointment? And what happened is much more curious and might reveal like all of the different triggers that led up to this patient being late and maybe yelling at reception and like that are perfectly understandable under the circumstances, and given the patient history, and then allow for empathy, validation, compassion, and more efficiency. I like to add that because often, like again, trauma-informed communication and empathic communication can seem a little daunting and open-ended. And it turns out that they're more efficient than the alternative, which is not knowing what your patient needs or wants.
Mm-hmm. And I hope our listeners find that as they practice these things, it's both truly an investment in a more efficient and effective visit. And I think you'll also just feel more connected to them at the end. So it's rewarding as a physician. It's rewarding. Those are the days that you're like, ooh, I think I did something for someone today that was helpful, even if it was just sitting with them and acknowledging their experience. I think a pitfall I will add is, to not or to avoid presuming what a patient's experience was like for them, and therefore offering reassurance that may or may not be what they need to hear. So the example I give, to self-disclose, and Dr. Ellwood knows this story, is many years ago, I was in the middle of having, I was hospitalized for a ruptured ectopic pregnancy. And in the acute phase of this illness, when I was being put on monitors and getting ready to go back to surgery, one of the medical team where I was, this was in another state, said, at least you know you can get pregnant. And I thought, that is just the least helpful thing that anyone could have said to me in that moment. I just didn't even know what to do with that. And I got that a lot later, because folks knew that had been a struggle. And so I thought that experience as a patient taught me so much about the power and potential harm of especially someone in a clinical role trying to let me know in a way without realizing they're doing it. Like, here's what I think your take on this should be. Here's where I think I want you to end up. And we all find ourselves doing that. And so avoid sentences that start with at least, and instead, sit with whatever the patient's offering you and validate it. That sounds awful, or maybe they offer you how they felt about it and you can validate that back. Oh, that sounds like it was really painful for you, or really tricky for you, or confusing, or scary. And there's often like nothing to do. They're not really interested in you bright siding it for them, but they are really interested in a person in a position of power, like a physician, acknowledging or validating that experience as difficult for them. And I think we underestimate how seriously sometimes patients take even the things we say that aren't prescriptions and orders and education, that we carry that power all the way into those kind of casual moments of really being able to validate or invalidate someone. And I'll tell you, just a few weeks after that happened, I was in follow-up with my PCP at the time, who did the opposite thing and said, without preempting, like, you are allowed to feel however you feel about this. However you feel about this is okay. And that was so, so powerful to me, as a medical student at the time, that's often what I use, is that I validate it, and then, oh, however you feel about this is okay. There's no wrong way to feel about what you experienced. But please, for the love, don't start sentences with "at least."
That's a really hard thing today. I don't want to, I mean, I guess those sorts of statements come from a place that I think we all know, that we want our patients, we want everybody maybe to feel better. And there's a real, for clinicians, a real tension in this moment, in not knowing what to say, and in like, in your whole maybe background having the intention to try to fix things, and then in that moment of not knowing what to say, trying to fix it, and then potentially doing a micro harm or a macro harm in the process. And that idea of validating and permissiveness, letting people know that however they feel, that's the way to feel at this moment, and it could change, and that's the way it is so helpful and skillful, and it doesn't fix anything. And sometimes that's what people need.
But it does build trust, I think, or it builds
Oh,
it
yeah.
builds something, right? It doesn't fix anything, but there is an intervention happening, or there's something being reinforced there that's positive,
Yes,
which is great.
it's validating and normalizing. That statement alone, with the right timing, is a whole intervention. That stand alone, everybody, when combined with maybe the right pause or silence for reflection and processing. But those kinds of things have a really deep impact that are hard to acknowledge in the hustle and bustle of CPT codes.
Yeah, that's what I was just reflecting on, is I guess in the end that so much of the theme here is that um, we don't want to let kind of the mundanity of our day-to-day lives as clinicians invalidate the, N of one experience that our patient is having or has had, with whatever the issue is that is the center of the dialogue that day, or a part of their context. Like, we don't want to let the routineness of our work and the fact that we've seen a bajillion of every kind of, really difficult thing, dilute or in any way reflect to the patient that thing that they've experienced for the first time ever, um, maybe is not much. We really want to find those ways through all the skills we've talked about today and the approaches we've talked about, to be with them in that moment, or to talk about that thing with sincerity, and with an aim of continuing to build and reinforce their relationship with us, but also each time that patient, like, we are each stewards of that patient's relationship with the healthcare system. Every time they see us, and we tell our learners this, like, you are a steward, um, and you're carrying with you the weight of all of their other experiences, however tricky they might have been. And so I think that that's a really humble responsibility as well.
So I want to be really respectful of everyone's time. In a moment or two, I'll sort of summarize what we talked about and offer my expert colleagues the opportunity to correct me or add some things. Are there other other epiphanies, thoughts that you'd like to add before we do that sort of wrap up section?
The one thing I'd probably add, I just love like how we talked about the not at leasting and to validate and to ask for permission. And I would just encourage the like ask for permission, especially with like physical touch. So I think sometimes depending on the person and the time, physical touch could be comforting or it could be very triggering and very uncomfortable for a person. And so asking for permission, like, is it okay if I hold your hand? Is it okay if I listen to your lungs and to your heart? And the the permission to say, I know that I am physically addressing yourself or your body, and I want to make sure that that is okay with you and that I can proceed with that. Is just touching someone or doing, especially physical contact without that is something I would avoid. And asking for permission is how I would address it. So
Related to that, and we talked about this a little in episode 1, and Dr. Ellwood also knows, we both feel strongly about asking permission to talk about, to explore or interrogate folks' relationship with their body, specifically with weight. And because that's something that comes up so much across different specialties and potentially folks listening, I would just add that. I know in general, we're always talking about bodies in some way when someone's coming to the doctor, but really specifically, we underestimate the ask emotionally from folks when we address their weight, and it's something we address a lot, and very routinely. And so I would add that to the mix as well.
Well, I think it seems like this is maybe the top line of the trauma-informed communication like show here, is if you take nothing else away from this, ask permission. Would it be okay if we talk about this? Would it be okay if I listen to your heart and lungs? That kind of asking permission is trauma informed because it respects people's autonomy. It's trauma informed because it gives some predictability about the next potential step. And it's engaging in teamwork, which ultimately is going to take you towards something that is going to be more patient-centered. So that's the headliner, ask permission. I think that there are other things that we talked about that are super important, right? We distinguished between that what's wrong with you versus what happened to you. We talked about some nuts and bolts kinds of things around sitting down and leaving a place for an authentic human connection and an open-ended question. How are you really? How are you after this difficult experience? Rather than leaning into the technical and the interrogative, like leaning into the humanity and then following up on the details as needed can be a way of creating that patient-centeredness. We also talked just about being really permissive when we are asking questions about trauma, to leave people the opportunity to opt out or to simply talk about what's difficult about the current experience in the moment and not necessarily talk about the whole history. Yeah, I don't know what else am I leaving out?
That was good.
Pretty
You're a
good. I
good
mean,
summarizer.
I've been practicing. I've been practicing. I think one thing that there are lots of resources online for trauma-informed care, and I think people will explore that. One of my favorites is the Trauma-Informed Care Resource Center. They have lots of materials that I would encourage folks to explore after this podcast, and layers and layers of both systems and individual, like clinician-centered strategies for implementing trauma-informed care, which I think are a part of patient-centered communication. Thanks for listening to this podcast. Thanks for being here, Stephanie and Kari Beth, my friends. Dr. Ellwood and Dr. Watts.
Always
You're
a
amazing.
pleasure.
It was so fun. I love getting to chat with you guys and I appreciate just the opportunity to talk about something so important. And so thank you
Yeah.
both.
We know how
Yeah,
important it
thanks
is
for
to
being
you,
here.
and that is why we knew you'd be such a great person to talk to. So thanks for hanging with us.
Take care, everyone.
All right, bye.
Bye.